Okay, Hassan, you can still hear us okay? Okay, good. Welcome, I'm Mark Kittleson, Chair of the Department of Public Health. This is our bi-weekly, I guess it is every 2 weeks, seminar. And this year, this week we have two speakers. Both are actually on campus, George Contreras and Kevin Pohlman. They're at the Center for Disaster Medicine, not the Center for Disastrous Medicine, but the Center for Disaster Medicine. And they are, and I'm going to let them explain a little bit more about the uniqueness of this center. They're relatively new. They've been on site about a year now, a little bit more than a year. The center has gotten sufficient funding that they knew that the director couldn't do it by himself, so they ended up hiring both George and Kevin. We've got this incredible program right in our back door, so we wanted to share that opportunity. It is being recorded, so people will be able to look at this on, all you have to do is go to our public health homepage, and there's a list of speakers you can observe, not just this, but also any previous speakers. So with that in mind, who's going to go first? George? Yeah. George is going to go first, so thanks a lot.
Good afternoon, everybody. Hi to everybody that's visiting us on Zoom, via Zoom. My name is George Contreras. Thank you for coming. A little quick about myself. I've been working at EMS in public health and healthcare for about 28 years now, mainly in New York City, but I also do a lot of work and teaching abroad, internationally, focused on Spanish-speaking countries, but not limited to such. So a lot of South America, Spain, some work in Australia and Africa. But today, I'm going to talk to you about the work that the center does here at New York Medical College. I'm very happy to be here today, and again, thank you all for coming. We're gonna do introductions so we don't get cut off. So.
Sure. Good afternoon, everyone. For those of you who haven't met me, I'm Kevin Pohlman, Assistant Director over at Disaster Medicine with George, and my background is also pre-hospital, emergency services, first response for the last about 20 years or so. But alongside that, I also have a background in academia, and before coming to New York Medical College, I was the Director of Education for a number of healthcare institutions, Director of Simulation for Mount Sinai's health system for quite some time, and bringing that here. So look forward to speak with you in a little bit, but I'll leave it to George.
Great, thank you. So yeah, if it wasn't clear, my background had started off as being an EMT, emergency medical technician, then became a paramedic in New York City. So director of EMS for a couple of hospitals in New York City, then director of emergency management in New York City as well. So, and like I've been teaching undergraduate and graduate level for some time now. So let me start off by saying, why isn't this working? I don't know. Perfect. There we go. When is National Preparedness Month? Anybody? Raise your hand. Anybody? When is National Preparedness Month? Huh? Somebody says September. Anybody else? Lucky guess. Lucky guess. Yes, September is National Preparedness Month. So it was particularly meaningful for us to do this talk during National Preparedness Month. So I know that Dr. Alamgir and Dr. Kittleson picked us specifically because they knew it was National Preparedness Month. But I bring that to light because I think it's important for all of us to be aware. There's a lot of activities you may or may not have seen in the news, different agencies providing information because it is National Preparedness Month. In the folders in front of you, we included a brochure from FEMA that has some information, has a lot of information online that you can get. I'll also put up some additional websites that you can go and get more information. Because I really personally feel that it's really important for each one of us to do our part to be prepared for whatever could happen. And as we know, things can happen at any point in time. It's not that it's going to happen from Monday through Friday, 9 to 5. It can happen at any point in time. That being said, what does personal preparedness mean to you? It's going to be very interactive. Sorry for the folks that are online. So what does personal preparedness mean to you? Can someone tell me what does it mean when I say personal preparedness? What does that mean to you? You're dying to say something. I know you're.
Having a plan for what you're going to do should something happen to you.
Good. Having a plan. It's actually one of those key steps that the Office of Emergency Management wants you to do. Have a plan. Have we done this before? Is this new? This is new? Yeah? Anybody remember the days when we used to do fire drills in schools, right? That's preparedness, right? We used to, in places where are prone to earthquakes, guess what they do? Earthquake drills, right? In schools, you know, what the children have to do when the alarms go off or something happens.
Evacuation plan.
The what?
Evacuation plan.
Evacuation plans, yes. If you're in flood zones, if you live in a flood zone, what do you see around the streets? Evacuation routes with the blue signs, with the arrows, with the little person running, right, with the big wave behind them, right? Those are all plans of people, what people need to do, right? And it's really should be an important part of our everyday life for something could happen that we need to be prepared, all right? We think about the typical emergency where you may need an ambulance, police, or fire, and you call, what do you call? What do you call? Don't say Ghostbusters. What do you call? Right, you call 911, right? But what if something major, larger occurs? All right, so this is kind of what we're here to talk about a little bit, this is kind of the background. And everything that we're talking about today, you have to remember it's very contextual. Why do I say that? Because we here in Westchester may have certain hazards, right, that other places may not be on the top of their list. For example, let's say in Miami, might have different hazards than right here in Valhalla. Can you think of one hazard that we have here in Valhalla that Miami doesn't have?
Blizzard.
Blizzard, good one. That's a good one. Another one.
Good one.
There's another one. It's out there. Okay, snowstorm, kind of related to the blizzard, but yes. Weather related. What else? Come on, folks. Where are we right now? Valhalla. Bioterrorism. Oh, equally here as it could happen in Florida. Anybody heard of a small little place called Indian Point? How far are we from that right now? Less than 15 miles. Less than 15 miles. All right, so just keep that in mind. That would be a large catastrophic event if there were to be an actual meltdown. All right, Florida doesn't have to worry about that, right? But that's what I'm saying. Everything has to be contextual. Like situational awareness is very important. That's why when we do trainings and we bring people from other parts of the world, or we go and do trainings, it's important to understand the society, the culture, and how that plays into their preparedness. All right. In Spain, where I do a lot of work, in Spain, we talk to them about mass shootings. They look at me like I'm an alien. Why? Because in Spain, they're really, really strict on gun control. It is really hard for any person to really just have an illegal gun. So for them, when we talk about the issues that we have here in the United States and other parts of the world with mass shootings, they really take that, and it really doesn't mean that much to them because it doesn't really, they don't feel that as a threat for themselves. All right. Anybody know who this is? I didn't make this up. This is actual. You can. It's Elizabeth, right? On weekends. And it looks really funny. It actually does look like you. That's great. I'm going to send you that. Is that what you were wearing for Halloween? So this is an actual campaign that the New York City Office of Emergency Management is just recently launched. She's called Ready Girl.
Oh, Ready Girl.
Ready Girl. And the reason,
I think it's good that it's a girl, though.
well, I'm sure there's a lot of reasons why they chose it to be a girl, but they really use it to try to get the message out to the younger population in a non-threatening way. Okay? Comics, cartoons, animation. So this way they get the message out. So this is actually a legitimate superhero. She's called Ready Girl. I did not make this up. I wish I did, but I didn't.
That is fine.
Some other websites where you can get information on disaster preparedness, on personal preparedness, you have FEMA, you have ready.gov. Here for Westchester, if you're interested, the third one is Emergency Services, the Office of Emergency Management for Westchester. You can go click there, you get a lot of information, how to make a plan. And important to know, are you in a flood zone? Important to know, right? Are you in a flood zone? The Red Cross, and then also the last one is the New York City Office of Emergency Management. All right, it's very interactive as well. They have a lot of programs, especially this month. You're probably going to see them out there of their campaign is called Ready New York. Okay, and it's really to go out there into the community and really talk about what they can do. All right, so enough about that. That's kind of the background of why it's so important for us to be prepared. Now, the Center for Disaster Medicine, how many knew that it was established in October of 2005? For those that are faculty and staff here, since 2005, it's been around, okay? It's not new, all right? And it serves as the only academic health sciences center and principal academic public health resource to local health departments in the Hudson Valley region, all right? We're expanding that now. We go beyond Hudson Valley now. We're outside Hudson Valley, even international. Okay, we're becoming a resource for other folks to come and ask us how things are being done in New York State, New York City, Hudson Valley. So we're very proud about that. All right, some key personnel, just for you folks to be aware of. Dr. David Markinson, founding director of the center, and now he came back recently. Now he's director again of the Center for Disaster Medicine. Myself and Kevin are the two assistant directors. We have Dana Kostitz, who some of you may have met, some of you here that are on campus. She's our administrator. And we have Dr. Michael Riley, who some of you who have been around have also probably met. He was the immediate past director of the center right prior to when Kevin and I came. And we also have, he's also a fellow, a senior fellow. And we also have Dr. Shirlita Ambler, right? Another familiar name. She's also one of the fellows for the center. Okay, why did the center come to exist? Well, there was a need, right? A big need, a big gap, and to try to come up with how to better prepare different sectors for public health emergencies, disasters, terrorism, okay, at the national and international level. Okay, when we talk about disaster preparedness, a lot of folks focus on the terrorism part, right? Because that's what captures your attention. It's what's most visible. For us here in the New York City area, even though it was 18 years ago, still a very powerful mark that was left on September 11th. Okay, so that's what terrorism is very dear to us. But we also want to be a resource for other organizations, other departments, other countries. All right, so we can try to solve problems. Public health emergency preparedness is a big issue. You know, just want to think about Ebola a few years ago that made its way into the United States. All right, so planning, response, and now even so with all the things happening with mass shootings, tactical medicine has become a really big thing. It's unfortunate, but it is. So the key focus areas that we have here are really research, broad-based, interdisciplinary, training, education, curriculum development, which are some things that we're helping local entities as well as abroad. We're helping shape new programs in other universities, in other countries. And then we're also providing expert consultation for public health related issues, terrorism, public health emergencies. We will talk a little bit about one of the things that the center is doing that started last year. As I said, a lot of the consultative services provided by the center are in support of federal and state grants. We were fortunate enough to get renewed last year from the New York State Economic Development Fund. Previously it was $750,000 that they gave to the center, and they were renewed for a little bit over $900,000. And we're hoping that we can continue to get that grant funding. All right. We have a lot of expertise between Dr. Markinson, the fellows, Kevin, myself. We bring a lot of knowledge, practical and theoretical. So we're able to comfortably help other organizations and departments who want to help improve their level of preparedness. And so we also started to do some educational activities as well. Since 2005, as you can imagine, thousands of people have been trained in one way or another by the center, private sector, public sectors as well. And we've worked also with different departments here at the school to offer some awareness level lectures about public health preparedness and the center itself. All right, these are just some examples of what the center has done. Some summer internship for disaster medicine with the medical school. So Kevin and Dr. Riley have taken the first year students who are transitioning into second year and focus some training on disaster medicine, on some research, how to do research, how to do pre-hospital care, disaster medicine. Okay. And then continue medical education for first responders, a key point here for EMS, fire, police. For example, the center was an American Heart Training Center back, I believe it was 2010. Then we became a National Association Emergency Medical Technician Training Center last year when I came on board. We also became a National Disaster Life Support Foundation Regional Training Center. So that means that we can offer courses to physicians, nurses, EMS personnel, fire personnel. These are all folks that are going to be at the front line of the work that could happen, of the events that could happen out there. And then this year, we became an American Red Cross licensed training provider. So now we've also expanded our portfolio to be able to offer basic life support, advanced life support, and pediatric life support through the Red Cross. And we also have an advanced online credit program, degree certificate program that was started in 2006. And that's also something that's run through the center, through the School of Public Health. And here's just some projects that the center has participated on in terms of alternate care sites, right? When disasters happen, you're not going to have your typical ratios of nursing, for example, where nurses may have a 1:5 or 1:6 ratio. When disasters happen, those may change, okay? Limited staff, a lot of patients, things are going to change. The locations of where the service is going to be provided might change, okay? Something that's really important during disasters, we have to keep in mind, the people who respond, we have to make sure that they're safe. Make sure environmentally that the environment they're working is safe, okay? Just to give you some example. And these are some of our previous partners. We've worked with a lot of the local health departments, as you can see here, a lot of local, national, and we have also some international entities that we've worked with. But as you can see, a lot of places within New York and abroad a little bit. Just to give you some examples of some projects, we have hazard vulnerability analysis, EOPs, emergency operation plans. Every facility, every hospital, every nursing skill facility has to have mandated to have an emergency plan. Okay, because as you probably recall during Sandy, what did some of them have to do? What did some hospitals and nursing homes have to do during Sandy? Or after Sandy, I should say. Anybody? Bueller? Evacuate? Anybody? Anybody heard about hospitals that needed to evacuate because of the hurricanes, because they were flooded, because they lost power? All right, nursing homes got hit pretty hard along Queens and Brooklyn. Places in Staten Island got hit pretty hard as well. Pretty much different parts of the city and other places were hit pretty hard. And some of them are still recovering. All right, we're talking more than 5 years ago. Areas are still recovering. All right, some other projects you see here. So one of the things that was kicked off last year when we started, actually, at the same time that Kevin and I came, was a hospital disaster course. And this came out of the Las Vegas shootings and the Orlando shootings and Pulse. Okay, you could recall what happened there. There was a mass shooting, a lot of people hurt and killed. Okay, healthcare professionals in the New York City tri-state area were concerned about this. They felt a little bit unprepared. They voiced their concerns to the Greater New York Hospital Association and said, we need some help, we need some training. So the Greater New York Hospital Association got in touch with the center and they created this course. So this course is it's an intensive full-day course and basically a little bit of didactic and a lot of hands-on. And the reason for that is because they were worried about how will hospitals respond to these types of events. All right, unfortunately, we've seen them more and more frequently. Since then, we've seen a couple more events that have occurred, and we unfortunately have to be concerned that these things may continue to happen. So we've rolled it out. It takes a lot of resources to run these courses. And basically, this is the course. So a few lectures about some events that have occurred, such as Vegas and Pulse. We had, obviously have Parkland is there. Now we have El Paso, unfortunately. And these are just the ones in the United States. Okay, a review of the facility-specific emergency plans they may have. And then the other thing that was also added was the use of ultrasound during disasters. Why you say ultrasound? Any clinical folks here? Anybody? So ultrasound is it's a very useful tool that could be, you clinical, sir? Okay, what are you? MD, physician. Okay, good. So you can appreciate probably more deeply why ultrasound may be very helpful during a disaster. So during disaster, you may get a lot of people flooding your emergency room. All right. Typically, when someone comes to the emergency room and they need some diagnostic tools, they send them where? MRI, X-ray to help them out. When you have a lot of people walking through your doors and you have a lot of really injured people, you may not have the time or the resources to send all the people you want to MRI or X-ray. But using ultrasound at the bedside can be a very useful tool to have. It can help you prioritize patients, especially during disasters. Right? Triage. I'm sure you probably have heard of the word triage, right? This is a very useful tool during triage. So we talk a little bit about that, both a quick lecture and then some hands-on practice of how to use ultrasound. Then we also do what's called a tabletop. What that is we actually literally gather around the table and have a discussion of how the organization would respond to a particular type of incident. All right, there's no moving of resources, no victims, it's just a discussion. All right, and discussion is focused on a mass shooting or mass casualty incident type of event. That's one part. And then we have the actual exercise, what we call an MCI, a mass casualty incident, where you can have a lot of people presenting to the hospital in a short period of time. And that's really what we want to get the hospitals, the clinicians really focused on. How would they react? How will they take care of the patients given the limited resources? And we've had very good response to these courses. We're talking from level 1 trauma centers to community hospitals. Because what we saw during Vegas and Pulse is that the hospitals were very surprised and very overwhelmed. Okay, because things happen at different times of night. There was no real control of where patients went. Believe it or not, during a large-scale event like that, during a shooting, during, let's say, a bombing, I can't use us as an example because we have a hospital literally across the street. But if you were in a foreign city, Dr. Knapp, I'll just pick on you because you're in my line of sight. If you're in a foreign city, let's say, I don't know, Miami or something. If you're in Philadelphia, it is foreign. Let's say you go to APHA in November and you're in Philadelphia and something happens and you get hurt, some mass casualty event occurs. How would you know what's the closest hospital to go to? How would you figure it out?
Call 911.
How else could you figure it out if you wanted to go yourself?
I downloaded the app.
Right, you just ask on your phone, right? So actually, this is one of the interesting things that happened during Las Vegas and during the Pulse shooting. People, common folks, the public, right? And then people who use transportation apps like Uber or Lyft, and they were hurt, and they said, take me to the closest hospital or take me to the closest trauma center. It makes a difference.
Siri wasn't
Siri too, right? So it'll make a difference what you say. All right, and so we saw in Vegas, for example, they went to 3 different hospitals, closest hospitals, depending on what they asked for. All right, because that's how technology plays a role in what we do. And these are the course objectives. You know, talk a little bit about triage, talk a little bit about the latest numbers that are out there. Unfortunately, we have these things that are updated because more events keep occurring. So it's unfortunate that these things do happen, and it just stresses the importance of why we have to continue doing these kinds of trainings. Yes.
When I came here, I'd never heard of a Center for Disaster Medicine. Everything else I've seen has always been called Emergency Preparedness or Center for Emergency something.
Mm-hmm.
Is it, they call it disaster medicine because we're at a medical school, or is the intent just to work in healthcare centers regarding emergency situations?
So the intent is to not limit it just to healthcare providers. And I mentioned earlier, we actually reach out to first responders as well, because they might be the first ones who get there, like police, fire, EMS. So disaster medicine is a very multidisciplinary. So it becomes a way of reaching out and transecting all sectors, public, private, whatever they may be, and kind of get everyone on the same page to how they should respond.
I mean, then do you work in communities to help them organize a community emergency plan? I mean, when I was...
Oh, we certainly have done that. The center has certainly helped organizations and communities start to develop plans. That's what I mentioned earlier, the emergency operational plans. That's the response for how the community is going to react. That's the response where a hospital is going to react. What are they going to do? What, depending on the hazard, depending what the event is, it'll be very different if it's a power outage as opposed if there's a blizzard, you know, staff can't come, things like that. So yeah, that center has been involved since 2005, helping them. Okay. So far, since we started last June, we've done 8 hospitals, and we haven't limited ourselves to New York City. We've had hospitals in Albany, we've had places in Yonkers, St. John's, and we've had a lot, the majority in New York City. And we have, this is the 8 we've done so far 100 participants. The majority have been physicians, and that's what we really want to focus on, because they're the ones that really expressed their concern that they felt like they needed more training on how to deal with limited resources. You know, they take care of the clinical, they're not worried about the clinical stuff because they know it. It's a matter of how do we deal with limited resources with a large flow of patients coming in this short period of time. All right, if this can happen at 2 o'clock in the morning, they have to do with what they got. Yes, sir.
Not any questions. One of the lowest.
No, not so far. Well, we have, these are the ones we've done so far. And we're going to do Columbia University in October, and we're going to do White Plains Hospital in November, and we're even gotten up to Buffalo for January. We're already scheduled for January.
Good time for that.
Yeah, that's what we said. So yeah, so this is a little bit what the surge tabletop means, right? As I said, we just literally get around the table, we give them a scenario, and these are all clinicians, physicians, nurses, trauma managers. This was at NYU in Manhattan, and pretty much give them a scenario, let them discuss it. How would they deal with it? The first thing they need to do is, you see there's a floor plan of their emergency room. Because the first thing they need to do is like, what do we have? Who do we have in the emergency room? How are we gonna, what we call decant the emergency room? Meaning we have to do some quick reassessing right now, and whoever really doesn't need to be here, we're gonna send them either upstairs or home, or tell them you're gonna have to wait because we have a major event going on, all right? And then they have to work together with the inpatient floors. The inpatient floors have to start reassessing and discharging their patients because they might be getting a lot of patients from the emergency room. So this is not just a one department plan, it's an organizational plan. And so it's really important that this becomes a multidisciplinary approach, especially when they're thinking about it. The person there, he's actually the chief of the emergency department at NYU, and he was involved in the course itself. And this just shows a high level of importance that they give it, that they want to make sure that the chief to everybody that works beneath him or her take this course so everyone's familiar. Because if someone's working at 2 o'clock in the morning on a Saturday night, if something happens, they're going to have to manage this until other people come. All right. This is at NYU Brooklyn. I'm sorry. Yeah, this is NYU Tisch. The other one was NYU Brooklyn. So one of the things we do is we give them a lot of patients, and they have to sort out how they're going to manage those patients. Those are those triage tags that she's waving at you there. All right, they have to assess how they categorize those patients. Go. And so this was at St. John's in Yonkers, in Riverside. We've got the interest of local political leaders that get involved in supporting this because this is important for their constituents. It's important for the hospitals to be prepared. And then you have Dr. Markinson there, Dean Amler also involved. And here you have some staff from that hospital, as you can see, sorting out their patients on the table there. Then we have the MCI, the mass casualty incident. This is the part that most people enjoy, and you'll see why in a second. It's very interactive. It gets really real. What? That's true. It's either enjoy it, they love it, or they hate it, because it just can become very overwhelming. Okay. We use standardized patients, which are card-carrying actors that play the roles of victims when we do this. Okay. And what that means is we mock them up as best we can. This is at NYU Tisch. Blood, scream, they act out, they scream, they get really disoriented, they get belligerent, because all these things could happen during a disaster. All right, the staff have to be ready to handle the different type of scenarios that could happen. This is a small snippet of what would happen during a mass casualty event. You see people with different injuries, stumbling in on their own. And we try to focus on the fact that these people come to the hospitals on their own. Because if they were to come by ambulance, they would be notified. There's some level of preparation that could happen. But the majority of these events, historically have been showing up on their own, whether it's vehicle, police, Uber, Lyft, whatever, walking in, whatever the case may be. And that's really what catches hospitals off guard, is the fact that people show up without prior notification. These are all, as you can see, in an emergency room. This is one of the mannequins that we have that we use, high fidelity mannequins. All right, this mannequin can simulate a lot of different scenarios, clinical scenarios. And so, as you can see, the staff get overwhelmed. The point of the exercise is to overwhelm the staff. All right, and it's better to overwhelm them in this kind of scenario, let them get a little scared, and know they can appreciate why it's important for them to be better prepared. And during all this, remember, you may not just have physical injuries, you may also have people who might just be scared, who might just run into the hospital because, you know, that's a safe haven.
Can I just ask a quick question?
Yeah.
I assume you have a team of people observing
Yes.
how they're responding,
Yes.
reporting it.
Yes, and then we after each one of these, we have what's called a debriefing. They call it a hot wash, is a technical term, but debriefing. So afterwards we say, okay, how did you feel? How did that work? And then we go over things that we picked up that worked well, other things that didn't work well. And we've actually had such an impact that some hospitals had gone in on the day of the exercise, changed their plans because they said, wow, this was really off mark. We really need to change it based on what they did.
So the actual MCI event that we put them through is about 15 minutes long. We get one critical patient every minute for 15 minutes. That's nothing in comparison to what we've seen in Las Vegas and Orlando, but it gets them sort of stressed. The debriefing component of it is actually 45 minutes for each group that goes through. So we spend a significant amount of time actually pulling out their frameworks, you know, their frames of mind, pulling out their thoughts and looking at their plans and how they actually care for the patients. So there's more time actually put into debriefing than the actual event itself.
So the reason why it's important that 1 minute, one patient per minute that Kevin just mentioned is because during Vegas, the hospitals, when they have mass shootings, one of the hospitals reported getting 38 patients in 42 minutes. Almost one patient per minute. And we're talking critically injured patients, not little abdominal pain, headache. We're talking people that have multiple gunshot wounds that are bleeding out. So that's really what stresses them out. Yes, sir.
So if there's someone has internal bleeding, how come to go? Because like you need to rescue like very fast.
You need what?
Internal bleeding.
If they have internal bleeding, well, that's one of the important reasons why ultrasound plays a major role, is to be able to figure that out. Plus vital signs, yes. But ultrasound would help you, because you could see the internal bleeding with the ultrasound very quickly. So this is the debriefing that Kevin was talking about, right? I don't know what he's thinking to himself. He's saying kumbaya, but he's, yeah. But yeah, there's an immediate debriefing that happens after each one of these. So some of the things that came out of this in terms of, they really were really inspired by the critical thinking, the simulation. You know, they really loved the actors because they were really realistic. Some places they were really overwhelmed by the realism that were provided by those actors. You know, what do they want? They wanted to repeat it more. You know, once they got over the being scared the first time, they wanted to do it more. There just isn't enough time to do that. So what have we offered in terms of how do we share this information? Well, we've offered, these are the kinds of courses that we already do now. We do the course that I was just talking about. It's called the Principles and Applications of Mass Casualty Triage for Hospital-Based and Emergency Clinicians. That's the hospital-based course. Then we've done all these other courses like austere medicine and tactical environment, which Kevin will talk about. And we've done symposia, one this year, one last year. And we've done other courses as well for different sections. And what do we do with this information? Well, we try to share it to other sectors. So as I mentioned earlier, with the School of Medicine, these are the courses that were given to the students of the School of Medicine, from electives to case studies in cardiology, to the intensive summer internship that I mentioned earlier, to how to manage advanced airways, which is stuff that really gives our students, our medical students, a huge advantage when they go to do rotations. And then how do we share this information? Well, we write up abstracts and we get accepted to different conferences. So we have our abstracts have been accepted at national and international conferences, which is great, so we can get the word out of the work that the center does. And then we also host and we serve as resource to other organizations, as I mentioned. So we've had, there's the EMS chief from Parkland, who was in command during the shooting. He came and spoke at one of our conferences here. That's Dr. Markinson. And we've had visitors from other academic institutions. This is Dean Amler with the Dean of Health Sciences from a university in Columbia, who came and spent some time. And actually, that dean is also a pediatrician. So they felt very close between the two pediatricians. They spent a lot of time together. And so they have an interest in getting to see how things are done in other places. They can improve their response in healthcare and other sectors as well. We also had the tactical EMS coordinator of Spain come and visit at one of our conferences, so they can kind of see lessons learned from our experiences and take that back and share. And we're currently fostering relationships to be able to do more with other organizations, both here and abroad. And you might say, oh, that's great. The center does a lot of stuff, a lot of research, a lot of publishing, a lot of abstract stuff, but we also get our hands dirty. And what I mean by that is when the hurricane occurred in Puerto Rico, the team led by Dean Amler went down to Puerto Rico to help in the response of that. And so they were contacted by the government. The dean put together a team with Dr. Michael Riley, and they actually went down there to respond to that. I'm going to go through this because we're running through time. So I don't know if you remember, Maria literally cut through the island of Puerto Rico, left a huge devastation throughout the island. Some aftermath shots that they were actually taken by our team that went down there was Dean Ambler, Dr. Michael Riley, a nurse that also went down. It was a and this is them when they arrived. They were welcomed by a governor and his team, and then they went out to work doing vaccination for people and the aftermath of that. So we really try to do boots on the ground as well as some research, some abstract stuff. We're not just, this is afterwards. Everybody there, very happy. They're still suffering, they're still trying to recover from that. So here's a quick video just to kind of give you even more. This is right at 7th Dana Road.
The Center in New York Medical College has a large impact on both the community and companies. We help the community prepare for disasters, terrorism, and mass casualty events, training EMS, law enforcement, fire services, but also businesses, schools, hospitals, how to prepare and respond. We have rooms set up to mimic
all at Dana Road.
Be a bomb-making facility, a meth lab, and we have
Not the real meth lab.
simulate actual patients they talk to, they breathe. We have a sensory overload and deprivation room. And sometimes you may go into an area with no sound, no vision, and get lost. And then other times you may have different distractions. And so under fire and in these very difficult rooms and situations, law enforcement, EMS, and fire learn how to protect the public, protect themselves, and provide medical care to those who need it. Our research helps in multiple ways. At the basic science research level, it's really designing antidotes and countermeasures to terrorism with chemical agents. But also it's an applied research, which is saying when you have a mass casualty event of hundreds of people showing up at a hospital, how does the hospital manage those patients? How do they creatively use their medical technologies in novel ways to be able to respond appropriately? One of the great things we're able to do at New York Medical College Center of Excellence, and this really resonates with me as a pediatrician, a former first responder, is we're providing people the tools to prevent issues such as disaster, terrorism, but even more importantly, once some of those events happen, it can make the difference between someone being saved and someone not being saved. Having a police officer, EMS, firefighter who go into these complex situations, provide medical care, and bring someone out and save their life is one of the great things we're able to do.
Right. So that was just a small snippet of some of the things that the center does. So my background, like I was mentioning earlier, I have a background in first response, emergency medical services as a paramedic for almost 2 decades. I've worked in communities of Newark, New Jersey, Jersey City, Patterson. So not the slowest communities, pretty busy, and what you'd call urban. I've also worked in lower Manhattan and the Bronx as well. So one of my keen interests over the years that's developed is operational medicine, or what we'd like to consider tactical EMS, tactical medicine, as well as cognitive load and skills acquisition. So that's where my background in healthcare simulation, and medicine has sort of brought me. So disaster medicine, we kind of mentioned before, it's not just the preparedness. I like to think of it as the actual bringing of the medicine, bringing of that healthcare to the front lines. So operational medicine is something else we've sort of embarked on at the Center for Disaster Medicine, something we began our focus in. And the reason being is many of our constituents are first responders, EMS, law enforcement, and the fire service, amongst others. Recently, we were able to bring in some of our law enforcement colleagues from Westchester, Lower Hudson Valley. In January, we're actually hosting the Putnam County Sheriff's Emergency Response Team, or their SWAT team, to do a similar event. But we bring them in. Some of them are medically trained, some of them are not, and it doesn't matter. We bring those folks in and we give them a new look into how to perform life-saving medical interventions, how to deliver healthcare in these hot zones or high-threat areas where you may not be able to get conventional medical providers to, whether it's pre-hospital EMS that aren't tactically trained or physicians, nurses, and the like. So we bring them in and we go through the current guidelines, the current science in tactical medicine or battlefield medicine. So we look at austere, unusual, hostile environments, wilderness, low resource areas, and we kind of translate that into medicine. So one of the exciting things and one of the more enjoyable aspects of my job is during these courses, I get to bring these law enforcement personnel through sensory impaired physical assessments. That's one of the things we do, just one of many. And we bring them through, and I have a video later on, let's say a smoke-filled room with lights blaring, sound blaring. It kind of gets their senses up, and it's to mimic the stress that you go through in a hostile environment, whether it's shootings or bombings, terrorism, the like. And we have them find a patient in this situation that you can't really, can't see anything, can't hear anything, go do an assessment, deliver a medical intervention, and evacuate the patient. That's one of the things we do. Another thing that we've incorporated into delivering care, emergency care, is, like George mentioned earlier, point of care ultrasound in these austere environments. So not only have we found that it's really, really great tool for mass casualty incidents and triage within the hospital environment, but it's a great tool to use also on the battlefield. And we've taken that from, unfortunately, the last 10 years or so from the Middle East, and they've brought back this technology and these clinical concepts to the home front. As well as thermal imaging in some austere environments. You actually saw in the video a thermal imaging camera in a very dark, unlit area and watching a medical procedure. So we've kind of integrated that into some of our care that we've been delivering as well. So we're not your typical classroom. So we use that flipped classroom idea. We kind of give our learners, whether it's law enforcement officers, EMS, hospital providers, their information up front, and we want more hands-on. Hands-on is what's really important to us because in terms of disasters, preparedness, and disaster, actual approaching a disaster, you want this sort of hands-on prep. So just some photos from our last law enforcement-based class. So this officer, actually, right here on the left, SWAT officer from one of our recent law enforcement classes, no medical training, and we were actually teaching him how to do airway management on a patient. In your everyday life, this law enforcement officer may not be doing that, but in an isolated, low-resource area, he might need to take care of either a suspect or one of his colleagues, and he was trained to do so. So the room on the right is actually our sensory impaired physical assessment room. We can create an atmosphere of total sensory impairment. So for sensory deprived environments, we shut all the lights off. The doors on both ends are closed. There are no lights. There's no windows. It's completely dark. You may have a single flashlight. If you do, the striping on the wall will sort of will kind of throw you off. And you still, once again, have to find a patient, have to address their clinical issue, and address it. In a sensory overload environment, we set the same room up, close the doors. There's no lighting, but what there is we fill it up with theatrical smoke to simulate battlefield smoke, and we have strobe lights and LED flashes, both different colors, red, some white. The red is simulate blasts, and the white is just for that impairment. Same thing, blaring, very angry music, just to give you that sensory overload. And same thing, either a patient or a suspect is in there, and the law enforcement officer has to go in, or first responder has to go in and address the issue. It's an excellent learning experience. So this is the, in the video, they talked about a simulated lab or bond making facility. This is it. It's also at 7 Dana. It's in one of the unused areas of the building. This is used more so for first responders to train in situational awareness, for hot zone clinical care, and for identifying threats. Quite realistic. Everything that is laid out on the tables in there or laid out in the environment was specifically chosen for a reason. There are very realistic components to whether it's the simulated meth lab or simulated bomb making facility. Very, very realistic components there. So this is just one example of that sensory deprived environment, sensory deprived physical assessment that we go through, just to show you how interesting of a learning experience this is. This was 2 trainings ago that we offered to, this was offered to law enforcement providers without medical training. I'm not going to turn it all the way up because it's loud. It's quite loud. So at the beginning, you saw this really bright sort of contractor light. That's to constrict the participants' pupils, so they have even less field of vision and less of an ability to visualize their surroundings. And it generates a significant amount of heat. So at this point, the person behind the camera actually has a thermal imaging camera. Another reason we use thermal imaging in these learning experiences is for safety. So we can actually see the participant and the patient, and if we actually have, we go through a little pre-brief with them. If anyone is sort of overly stressed or would like to exit the experience, they'll lift their hands up, we grab them, and we remove them from the room.
Wow. How long are they typically in that building?
In that room, it's typically anywhere from 1.5 minutes to 4 minutes, depending on how quickly they address the issue. So you could barely see, but right now he's applying a tourniquet to this patient's leg or patient's arm. You could see basically the hand in front of your face, and that's it. It's very difficult.
Basically, it's okay to get them to do this with their eyes closed.
Because of the sheer strength of the sound, everyone in the room is wearing double ear protection also, including the participant, but it still overly stresses you. It can. And that's actually something we do ask prior to the experience. That was about 2 minutes. So that's about average. We have had we have had over the course of running those sensory impaired assessments, we've had about 3 who've tapped out, who've gone through half of it and said, I need out, and we've extracted them from the room. So these are just some quotes that I love. And it really speaks of what we do. So experience is something you don't get until just after you need it. Unfortunately, we saw that September 11th, right? September 11th was a very big, unfortunate event that brought a lot of good change to our preparedness and the way we deliver medical care, the way we prepare for law enforcement, the way we prepare for aviation. So, unfortunate events sometimes bring some positive change. And I changed Zig Ziglar's quote a little bit, but people often say that preparation doesn't last. Well, neither does bathing. That's why we recommend it daily. That's one of the key aspects of why we are the Center for Disaster Medicine. So as we go on, many of our future projects include preparedness for hospitals, healthcare facilities, continuing the projects that we're currently working on, adding ultrasound, point-of-care ultrasound to many of the courses we currently deliver, as it's been shown from the battlefield and from recent clinical studies that it does have a great utility in the public health arena, in the preparedness arena, and we plan on continuing to consult other groups. If you have any questions, George and I are happy to answer.
Questions, and if you're online, you can, I guess, unmute yourself and ask. If both of you do at once, we may have to intercede and just let one person talk. Any questions or thoughts or comments?
Yes, sir.
The simulation that,
Can you repeat that so they can hear that?
Oh, so the question was the simulations, if we offer that to the public. So certain simulations, like the one you saw with the sensory deprived environment, or sensory impaired environment, those are targeted simulations. So we will offer that to first responders, we'll offer that to law enforcement, fire, EMS, we'll offer that to healthcare providers if they need it for some reason, and U.S. military.
because I would actually try that, although I would.
Well,
It's-
on the next training is you can come.
So it's actually, so the interesting thing is it's a lot more than what it seems. It's not just sort of going in there, finding an injury and intervening. So for law enforcement, one of the things that we have to do in a tactical physical assessment is actually sweep the patient, make sure that they don't have weapons on them, even if they're a friendly, even if they're a law enforcement officer. We do that because mentation-wise, if they're exsanguinating, their mental status is probably decreased or altered, and any weapon they have on them, even if it's their service weapon, should be removed because they're a threat to themselves. So it's going through that. It's removing, identifying or removing weapons. And then it's dealing with whatever the clinical need is. So it's a very interesting, different way to do an assessment or clinical intervention.
I want to. Yeah, very nice talk. And then I have a question about you are the early dispatch of the environmental stress. And do you have any some priorities stress compared to the national level versus new state level?
That's a good question. I don't know. Do we have any comparisons?
We have, no, we don't. You mean at the center that we compare specifically?
Yeah.
No, we haven't looked at national. We just base it on industry standards in terms of what we can expect for them to encounter. And like the training that you were saying, these are all based on lessons learned from Afghanistan, Iraq, best practices there, and how we can better prepare people that are working here. There are studies that follow health consequences, mental health. For example, there's a World Trade Center Health Registry, and they're following everybody from the attacks on September 11th. And that is a national study that's being followed for like 20 years, following people that lived there, responded there, or evacuated. That's like a national level study that's following thousands. They had originally in the first wave, they had 70,000.
And I'm sorry, just to touch on that, the sensory impaired and all the tactical battlefield austere things we do for medicine, that actually stemmed from a project that they worked on in disaster medicine a few years back that was requested by the Department of Defense. So a lot of the data that triggered the creation of all these skills and the course came from the Department of Defense. So it's all coming from battlefield, studies for the last. It's data from yeah, snippet.
Do a lot more.
Sure, but it's a lot of the information from battlefield data last 10, 15 years.
That means that you are the last slide shows tech medicine, and here too some of the domain you introduced us EMA and the TCC for them is in general national the project, right? Not
Yes.
Specific. You are the
Correct. So TECC and TCCC are just the guidelines that that this sort of tactical medicine is founded on. It's the guidelines for battlefield medicine, tactical casualty care.
Like UMC actually, here's why WMC is natural, but someone who would want that treatment.
Oh, it's a very good question. We're reached out to them and wait to hear back from them.
And many of the facilities have actually, like especially the pilot facilities, reached out to us immediately after Greater New York requested us to build the course. So there were some that were very early adopters and some that have now sort of heard about it and starting to get it out there. But that's why it's a continued project.
Do they pay for it? Or
So it's a state supported or it was a supported, grant supported created course. The course creation was supported by grant funding, and I believe many of the hospitals are using like preparedness grant funding to run it. I think we're basically doing it at cost for them.
Any other questions?
So my question is, during disaster, what's going to be are you going to be prioritized? Is it going to be evacuating first, patient, or the doctors or physicians are also very important process. Are you trying to make sure that those people are safe first, so that they can help? All the equipment, all those, because I'm sending out after sending out from the things that I was sending, they have floating in such an area of hospital. So let's say we have the generators and for the elderly dogs. So what's going to be the priority, and also while you're evacuating the patients, also how are you going to know which hospital has capacity to evacuate?
So the question was, how do you prioritize whether to save equipment or personnel during an evacuation? That he specifically brought up evacuation. So we can use NYU as a perfect example. They're located right by the water, and they evacuated their facility to other facilities. So when something in New York City, for example, something of this magnitude occurs, there's an Office of Emergency Management that helps coordinate all this process throughout the city. Okay, so that organization helps coordinate it, and they know, because they work with like the Greater New York Hospital Association and other agencies, they know which hospitals are not in flood zones, and they know which hospitals have what capacity to take. And they practice this year round. So hospitals will practice evacuating, other hospitals practice receiving. So when something does happen, they know where they're going to direct the patients. So the patients from NYU went to different facilities, because you're not going to send all 400 patients to one facility. You're going to spread it out. So that's why this takes a lot of planning, a lot of practice. So when something does happen, it's not the first time that they're pulling out those plans saying, okay, where are we supposed to go now? All right, this is an ongoing basis. And so the city's involved in a lot of this as well, because they help coordinate. They have to provide additional ambulances, additional equipment. They can relocate additional resources and send a whole bunch to the other hospital. So that's how they do it.
Although I'll add a caveat to that each facility is responsible for creating their own plan, activating their own plan, and executing it as well, with assistance from the city and whomever. And each emergency, each disaster is unique. can prepare so much, but, you know, decisions need to be made, I believe, on a disaster by disaster basis. They're not all the same.
And also just want to end by saying that we all have to play a role in this whole preparedness. So all disasters are handled first locally, right? And by locally, I mean the local area entity. And so we are become like, if something happens, we have to be able to take care of ourselves, take care of our families, right? Because if I'm a physician, if I'm a nurse, and I work at Westchester Medical Center, and I haven't prepared for how my family is going to deal with some major event, am I going to be worried about going to work, or am I going to be worrying about my family? Right? So if I'm not ready to do that, I have now lost myself as a resource to the facility who's counting on me being that resource. So personal preparedness is really, really important, no matter what industry you're in. Yes.
Yeah, no, I totally agree with that
Oh.
because, yeah, it's just like you go to a movie theater now, you check the exits, right?
Yeah.
I mean, that's kind of ingrained in us now, right? And the same with, like, you're talking about hospitals. Like, everybody laughs at me. Like, say I go, like, with my sister away for a weekend or something, and I'm like, okay, where's the hospital?
Yeah.
What's wrong with you? I'm like, no, really.
These are
I
things you
never
gotta
been
know.
here.
These are things
I
you
mean,
gotta know.
If something happens, what are you gonna do? So it's just those type of things. And like a long time ago, we had gotten, and I like this thing about your emergency kit, because like everybody should have one, you know, and just be like, whatever, throw it in your closet,
Yep.
have something in your car.
That's part of the
I don't
personal
know.
preparedness. It's called a go bag,
Yeah,
right? You should have it because something could happen that may force you to leave your apartment or your house at a moment's notice. The most common thing that comes to mind is a fire,
yeah,
right? That you have to literally leave without really being able to put stuff that you need together, all right? Or other people say, you know, when you're expecting a child, you have that little bag ready to go to the hospital. But I like to use fire because the fire can destroy your house or your apartment and you may not be able to come back. So you may have lost what you wanted to. So as a homework assignment for everybody, go ahead and start having those discussions about how to prepare a personal plan for home and prepare a go bag. Because you never know when something can happen out there. I have a go bag. I have several. Thank you. Oh, quick. No, I refuse.
Thank you for recording.